Hi, everybody. I'm Samir Parekh, Director of Multiple Myeloma at the Icahn School of Medicine at Mount Sinai. I'm here to talk about a recent oral presentation at ASH where I described the earlier use of cilta-cel and its correlation with a healthier immune system leading to durable responses. This was based on a study called the CARTITUDE-4 study, in which patients were randomized to either get cilta-cel in 1 to 3 lines of treatment or get randomized to standard of care. This study, in contrast to older studies, had patients that had received fewer prior lines of treatment. CARTITUDE-1, for example, had patients that had at least 3 or more lines of treatment and were lenalidomide and proteasome inhibitor refractory and then got cilta-cel. And as has been previously published, the outcomes from CARTITUDE-1 were exceptional. 1/3 of the patients were disease-free and progression-free with no treatment after cilta-cel after 5 years. With CARTITUDE-4, similarly, there is a survival advantage over a standard of care that has been demonstrated both in terms of overall survival and progression-free survival. We now were able to parse the clinical advantage by lines of treatment, and patients that had gotten 3 or more lines of treatment had a progression-free survival of about 34 months. In contrast, if patients had only 3 lines of treatment, that jumped to 50 months. And in patients that had gotten 1 to 3 lines of treatment, the median survival isn't even reached, likely greater. Overall survival, similarly, was much higher in patients that got cilta-cel after 1 or 2 lines of treatment as compared to 3 or 4 or greater lines of treatment. These patients were relatively balanced in their disease burden, age, and other characteristics. So we hypothesize the reason these patients were doing better was because they had a healthier immune system going into the CAR T therapy. And to test this, we looked at bone marrows from CARTITUDE-4 patients at baseline, day 28, and at 6 months, analyzed them by RNA-seq. And we also looked at peripheral blood before CAR T by immunophenotyping to look for T cell fitness. What we found from the bone marrows was that there was robust myeloid activation. So these are anti-tumor myeloid cells bearing an M1 phenotype. There was also robust T cell activation across the board after CAR T. And in addition to that, patients in earlier lines had greater activation of T cells. When we looked at the converse, patients doing badly, they had greater and immune suppressive cells. For example, regulatory T cells were higher in patients that were progressing in 18 months. Regulatory T cells were also higher in patients that got CAR T later in lines of treatment. This suggested that CAR T earlier was creating an immune phenotype that was better. The strongest evidence actually came from the flow cytometry of the peripheral blood, where there was an increase in CD4 naive cells. These are cells that have been shown not just with cilta-cel, but across different CAR Ts to be associated with durable responses. They were higher in the patients getting long-term remissions and in patients that had received fewer lines of treatment. So taking all this together, it suggests that giving cilta-cel earlier in myeloma treatment is beneficial and supported by these immune correlated, showing that there's a healthier immune environment. I think this is extremely important to get out there to the patients and the treating physicians, because they need to discuss with their doctors whether they should consider CAR T as an option even if they have failed 1 line of treatment. And then they can be referred to a CAR T center, have a full discussion on the pros and cons, and decide the best way forward. Thank you.